Neil has been placing and restoring dental implants for over 30 years now. After completing an MSc in fixed prosthodontics at the Eastman in London in 1987, he was awarded a PhD at Imperial College in 1992. He then invented RFA, and that's the reason for us being here today, and the technique that became Osstell, the world standard for measurements of implant stability. He undertook research with P.I. Brånemark and Thomas Albertsson in Gothenburg, Sweden, and was awarded a second PhD for his work there. After that, he returned to the UK as a professor of restorative dentistry and biomaterials at Leeds University. And in 1998, he also invented a dental implant system and raised venture capital funding to secure its development, and continue as a CEO for that company for the next 10 years, where it showed exceptional growth and success. He then moved back to Australia to return to academia as professor of prosthodontics at UQ and latterly James Cook University. Of course, he's lectured and published widely and internationally, but his real passion is clinical patient treatment and teaching. So it's a great honor to introduce Neil. Please, the stage is yours.
Well, pause and rewind. So, ladies and gentlemen, thank you very much for putting up with me for that very small break. I would like to thank Osstell for their very kind invitation to this beautiful city and this most interesting congress. And I would also like to congratulate the previous speakers on what I thought was raising some very interesting questions and elegantly and eloquently answering them for us. And it follows on very nicely about some of the things that I'm going to discuss today. As we've said, implant stability and osseointegration has been a great desire for all of us as clinicians to be able to measure. To be able to measure to the benefit of our patients, to help us to treatment plan, to diagnose, to follow up and maintain. And no more than ever, it is so important to be able to assess that parameter. But equally well, we all understand how complex it is as a parameter. And there are so many different factors, and it's a physical, a mechanical, but also a biological process which changes and evolves. And it doesn't just go up. Things go down, things change, bone deposition varies. We've all seen wonderful examples of that in the scientific literature. So as we said, some probably 30 years ago, we had some thoughts and some ideas, and they started rather elegantly and eloquently with music, because, as you know, Osstell is called resonance frequency analysis. And music is about resonance, it's all about resonance, and it's evolved in a very simple way to what we now know as the tuning fork. And the basic principle of any tuning fork as a musical instrument is to give us an indication of the stability and stiffness, but also the length of the tuning fork. That principle, in its absolute term, is applied as it is in Osstell. And this was one of the early designs of transducer, which was excited electrically to vibrate. And at a certain resonance frequency, we could measure that frequency and relate it to the stiffness and stability of the surrounding bone. And it's that foundation and that principle which has taken us through the last 25 years. The technology at that time was basic and simple. What we're now seeing is reaping the benefits of what technology is giving us today, not only in terms of hardware, but also in terms of access to information and the ability to understand and process that. And it's becoming such an important part of our everyday life. We would like to know exactly what the stability of this implant is in a patient at the time of placement, and also how it changes through the clinical lifetime. And one of the things that Bill talked about, which I thought was a wonderful phrase, was individualized healing protocols. That's what we'd like to see. If we can individualize a patient protocol to achieve the very highest long-term success, we'd like to be able to do that, and I now believe we can. So resonance frequency analysis gives us ISQ. So what's in a number? Well, numbers can mean lots of things, or they can mean nothing at all. I'll give you an example of a number, which I'd just like to show you for a minute, and this is the Las Vegas Speedway. It's interesting to note the disabled parking spot in the corner. I've no idea who parks there, but my number was 185, and that was 185 miles an hour. Now, the significance of that is not only having a wonderful time and being quite scared, but what does it mean? It means a very different thing whether that car is coming towards you or going away. It tells us nothing about direction. It tells us nothing apart from one simple parameter. But that parameter did give me a big smile on my face. So implant stability varies in different directions with quality and quantity of the surrounding bone. It may sound a simple and obvious thing, but it's terribly important. And in the 2 lectures we've just heard, it really highlights the significance and importance of understanding that parameter and the difference it can mean. So what we see here is an implant in bone, and it's in the mandible. The stiffness and stability of that implant is not the same all the way around. It's very different in one direction to the other. And that's a simple principle which applies in mechanics and mechanical engineering. But in order to fully describe that, and in order to fully understand what we mean, we can't use a single number. If we measure stability around the implant, we can see that clearly it's lower across the implant, where it's easier to bend the mandible. For the mesiodistal length, it's going to be a lot stiffer. It's not only in a simple site like that, where overall the implant is very stable, but it becomes really important in the cases we've just heard about with extraction sockets and immediate loading, where the bone-to-implant contact is not uniform and it's not symmetrical. We can be the best clinicians in the world, and insertion torque can give us an idea, but we can't really predict the stability of that implant at the time of placement, and it is important to know. So, for example, let's look at this molar extraction site, and we're looking to place an implant somewhere in the septum, and if we measure the ISQs, the first mode is 65, but then we look at it, and the second mode is much less. It's 45. Those 2 numbers are not the same. If you're using Osstell and if you're using ISQ, then those 2 numbers should be referred to separately. Don't average them, don't divide them, treat them separately. And again, I was so pleased to see the previous speakers doing that, because the difference is so important. What that's telling us is that this implant is not going to be symmetrical. And because of that lack of symmetry, we see it classically in the sinus region, where we saw one with, I think Jeff had 3 and 17. It shows that there's an imbalance. And it's the lower number that's really very, very important. So we want to be able to record that, and we want to be able to understand it and to save it. Now, in the older technology we've had, you basically have a probe with a smart peg, and you move it around, and you kind of work it out and see if the number changes. But it only really gives you an indication that there's one number. It may be the same value in different directions. That's just fine. But it's nice to know that there are 2 numbers. And you'll be aware of beacon, and one of the beacon instruments demonstrates for us very nicely and tests individually in both directions. We still have to move the handpiece a little bit and orientate the probe, but it gives us the confidence that we are actually seeing those 2 values. If they're the same, it's great. If they're different, we need to record them both. So things have moved on. We have a good understanding. We can talk a little bit about insertion torque in a moment, but for the moment, I'm going to dwell on what we've got as beacon, and everybody's got wonderful pictures of lighthouses, and this one's in New Zealand, but we'll talk about the new technology. And this is really to explain how the new technology works, but then to the wealth of things that we're able to do with it, and how we're to be able to use, to manipulate, and to benefit from the data. The simplest thing that I did a slide of some 30 years ago, wouldn't it be nice to have a traffic light? Wouldn't it be nice to have something that gave us a basic indication of stop, ready, go? And if we look closely enough, we can see that easily and readily on the new beacon instrument. And I find it quite friendly. I find it really helpful when I'm looking in a patient's mouth, the handpiece is near to the site, I don't need to look at the numbers, it gives me an indication we've got a reading, and it gives me a benchmark from where to go on. If things aren't so good, then I'll, of course, look at the numbers and the second display parameter. For me, where it gets really exciting is the ability to take it to the next step. And the next step is to capture that data in a simple way and an easy way where we can make much more use of it. I'm a clinician, I'm an academic, and I'm a researcher, but I'm ultimately, like many of us, a little bit lazy. And writing down lots of data becomes one of those great challenges. If we look here, again, we can see that very simple green light in this case, which is a nice, well-placed implant, and we can see the stability on the right, so we know we're doing something well. So, historically, what have we been doing with Osstell? What have we been doing with RFA? And what have we been doing with the numbers that we gather? So what do you do with a number? Well, if you've got a single number, some of us write it in our patient's notes. Some of us file it in the usual filing cabinet. But it doesn't really. We have many clinicians actually have, in a very dedicated way, recorded that data in databases of their own, in Excel spreadsheets or other formats or other media. That's helpful. It's helpful to them to understand and review those figures and to review that data. And many of those clinicians have written some excellent publications on the follow-up of their own patients' treatment. But wouldn't it be nicer? Wouldn't it be great to be able to get all that information together? And then we could really start to understand the variations and the effects and implications. And this is one of the things which I'd hoped for so many years, which is now starting to be realized. And that is the introduction of OsstellConnect the Cloud. This isn't a marketing discussion. I have no real connections with Osstell as opposed to a friend and a colleague. But what I'm passionate about is what we can do with this as clinicians looking to the future. You may have heard of OsstellConnect as an online web-driven database. Knowledge is power these days, but we want to collect it as easily as we can. What OsstellConnect can do is all these things. So it can create a personal cloud-based database. And you don't need to do any wiring, you don't need to do any complex data saving, you don't need to do backup disks. It's all there, alive and running on the web. And that makes life very easier. If you want to download information for your own scientific publications, just for your own review, if you want to do a summary paper for your patients to give your statistics, it's very common these days and increasingly common for clinicians to publish their own data for their patients in a little register. Of course, there's graphical representation and feedback and clinical guidance and treatment planning. That is when this data becomes intelligent. That is when this data and information can really, really help us to develop. If you switch on your Osstell and OsstellConnect, you'll get a simple dashboard like this, which gives you some indication of what you've been doing, what it looks like, and it's useful and it's easy and it's fast. And there's new bits of information that come up from Osstell from time to time, and it gives you an idea and the breakdown. Now, one of the questions that I've had, which I think is quite an important question, which we should all have these days, is what is the privacy of this information? Is it generally available? Is Osstell sitting there with this big dark database pointing fingers at clinicians? And the answer is not. It's anonymized. It's completely anonymized. So I can see this as a clinician myself of my patients, but other people can't. It's easy to track, it's easy to sort, and it's easy to follow up. The data is very friendly. I like the layout. I like the ability to follow through patients and to know where we are, and then to systematically start to look at plotting some graphs and some information. Exactly as I think Bill was saying, we can see a dip. We can see a dip in Osstell measurements, and Paul Rose and I have done some work on that. It means in some cases there is a loss of stability. It may be due to crestal resorption around the implant. It may be due to a range of parameters and factors. And it's really nice to be able to start to understand the significance of those factors and to look at individualized healing protocols where maybe we say, well, hang on a minute. And what is interesting is all the questions that have been asked today are clinical judgment calls. Wouldn't it be nice if we had somebody sitting on our shoulder which says, well, in a case like this, you know, there have been 583 cases, and this is the range of treatments that have been done, and it's very likely to succeed at a level of 82% if you do this. That would be really very nice and very useful, and that's where we're going from. You can export the database into a simple CSV file, and this just shows the structure of the database. The interesting thing is the variables that are measured. on the top. And they're measured and saved in a very simple way. So it doesn't take us hours to enter data. It's just a matter of a minute or two to enter the parameters, but it gives us information on risk, location, implant type, loading time, all sorts of factors which relate. So there's a wealth to be gained and to be used. So where are we today? What are we looking at today? What we're looking at today with Osstell is we've got some guidelines. There is a wealth of scientific data out there, and many, many researchers over the years have used Osstell as a benchmark to record variables and parameters. There are demonstrations and clinical cases and videos. But what is exciting is what's about to happen and how things are starting to develop. Wouldn't it be nice to be able to use this information in an intelligent way to give us more detail about the way things can happen? And this is a way we can lead to. So it's not just a number. It's not just about an ISQ. It's actually about all the clinical information that we gather at the same time and how it can be correlated. So we can understand which is the best thing to do for our patients. If there's new techniques, what's the feeling about how to use that new technique? Are there differences between different implant systems? Some of those questions we can already start to answer. If we look at the OsstellConnect database today as it is, it reflects about 180,000 measurements, which is a significant number in a relatively short time. Within a year or so, I anticipate it will be much higher. So, we've said what we've got. We've got a wonderful database. Academics and epidemiologists will get very excited, but what does it mean to me? So Connect is the answer. What is the question? So let's have a little look. Let's pick a Noble Biocare parallel implant, CC, its stability in different quadrants. So there's upper anterior, lower anterior, upper posterior, and lower posterior. No big surprises. The grey and the orange are buccolingual and mesiodistal. But I like things where there are no surprises because it helps to validate it for me. So when I do see differences, I can start to understand them. And this is taken from the data set. We can talk about number of samples in just a moment. Let's look at something that's valid. Now, if you look at the Osstell database, they have smokers as risk factors, they have bruxis as risk factors, they have smokers, bruxis who are risk factors. They have so many combinations that you can really start to analyze. I've just picked some smokers here versus non-smokers. So if I looked at the database, we can see a difference. It's not a massive difference, and one is placement and one is loading. But we can see an increase in primary stability, but we can also see a small increase in the loading situation. I apologize for the lack of error bars. It's just purely time that's not allowed me to do a detailed analysis. Then things get quite interesting, really. So let's compare, for example, Straumann bone level implants with Straumann standard implants with Noble Biocare parallel. Now, I could ask this as a question as to who thinks one is more stable than the other at primary stability, but I really didn't think it was terribly diplomatic. So, but let's look in posterior quadrants, and the N for each of these is well over 100. And actually, if you look 69 to 75, they're very similar. The primary stability of these implants is high and good. There's no real difference, which kind of I'm not entirely surprised about. The important thing as well to think about is that Osstell and ISQ measures stability, it measures stiffness. And that's what Bill was talking about, the interrelationship with insertion torque. And placement criteria can have an impact on insertion torque, as we know, between different systems. But ultimately, ISQ is really what matters. If we go back to the literature, the reason we're all here and the reason that we've all done the work is basically because of the publication of these studies which we work to. These all depend on a number of factors, and one of the most important factors on which to be able to base these studies is the number of samples. One of the things which I really believe, because we've already got 180,000 measurements, is that within a couple of years we'll have over 500,000 measurements. With that sort of work, you can do some real data gathering. You can make some really informed opinions. Of course, it needs quite sophisticated statistical analysis and things which are rather different to what we've been used to doing. And a type of analysis that I've used and I think will be applicable is a viable analysis. But what it will lead us to is intelligent diagnostics, is to actually give us information which can help us to make decisions if we're less experienced, but can also, it's nice to have on the back burner if we're using different techniques. So we're able to share common practice and loading and surgical protocols. So the risk of failure in this situation and the estimated time to loading is 14 weeks. The next one is, well, in this case, we've got a 15% risk of failure because the ISQ is a little bit different, a little bit lower, and the situation is different too. We may also be able to tell a patient their time to teeth in a simple and higher certainty. We may be able to know which implants work best in which situations. We may be able to share common practice regarding the choice of implants, which types of grafting technique. All this is part of our changing world. And wherever we look, data is king now, and we have that information and we have that knowledge. Now let's use it and really start to apply it. And I think it will really help us to gather and enhance the benefit of our skills for our patients. Ability, skill, and knowledge are still fundamental. Ability and skill we develop with practice and education, and knowledge we can build on. If we now have a simple way to have information which we can communicate to our patients using a simple diagnostic test, it can really enhance our overall experience, but also enhance our patients' experience. And it can help us to train and educate dentists of the future in a better and more comprehensive way. What we've seen is a number of ways we can benefit from this. We can benefit from a dashboard directly and immediately and now, but as you're all thinking, there are so many interesting questions we have the possibility to ask and get meaningful answers for. So what I hope we will see in the next year or so is a publication which is actually a report. And that report summarizes a number of those variables and fields. It looks at the impacts of risk factors on loading. It looks at the impact of grafting techniques and materials. It looks at success rates. It looks at different populations, which we now have the ability to do with a vast database. So I would really like us to see a report, and I would encourage Osstell to help to support to produce this, which we can share and we can understand and will increase our learning overall from the big picture. And I think that would be very helpful. Overall, I'd just like to say the beacon is bright and the beacon's Osstell. Thank you very much for your attention.